This is Dr. Michael Trainer. I have prepared this video to discuss total knee arthroplasty, also known as total knee replacement. Specifically, we will discuss the risks and complications associated with total knee arthroplasty, as well as answer frequently asked questions and also discuss instructions and expectations for patients undergoing the procedure. The first risk we always discuss is the risk of infection. Infection is most likely to occur following a surgery because of the incision that is made in the skin. With a knee replacement, the incision is made along the anterior or front aspect of the knee, and because we make that incision, there is a risk of infection. The way we prevent infection is patients will receive IV antibiotics during their surgery. Patients will also receive IV antibiotics following the surgery, but they do not need to go home on antibiotics. In order to eradicate or eliminate the bacteria that causes infection, patients are given antibiotics. The antibiotics can be taken by mouth or through the IV, and they will circulate through the bloodstream to find the bacteria and eliminate the bacteria. Unfortunately, with a joint replacement, the replacement parts do not have circulation. There are no blood vessels that go to the replacement parts, and the bacteria is able to latch itself onto the replacement parts, and by doing so, the bacteria avoids the antibiotics. If a patient has an infection in a total knee replacement, in order to eradicate the bacteria, the replacement needs to be removed, which means the patient has to go back to surgery a second time, remove the replacement parts. At that point, a spacer is placed, which is created by bone cement with antibiotics in the cement. The spacer is placed, and the patient then requires up to 12 weeks of IV antibiotics, as well as needs to be seen by an infectious disease specialist. After a period of up to 12 weeks, the patient will then require a return to surgery to remove the spacer and place the new replacement. With that said, infection occurs in extreme rare cases. If an infection occurs, oftentimes the patient will be sent to a joint revision specialist, which is an orthopedic surgeon that replaces replacements. After knee replacement, the skin will be red, the skin will be warm. This is very, very common and is not the sign of infection. Patient may have a small amount of drainage from the wound, and this is also not the sign of an infection. The greatest sign of infection is severe pain that is increasing. After the surgery, we expect the patient to have some pain from the surgery. We expect there to be warmth. We expect there to be swelling. But severe increasing pain and copious amounts of drainage, meaning significant drainage, is more of a concern. Small amount of drainage, swelling, redness, warmth is not the concern for infection. If a patient feels they may have an infection, we request that you call our office day or night, anytime you are concerned. We will see you in the office the same day, or if we're not in the office, as soon as we are available. We do not want you to go to the urgent care or the emergency room. If there is any concern, again, call the office, and if it's after hours, I will be notified and I will call the patient. Or if I'm not available, my physician assistant will call the patient. Do not go to the emergency room, because if you do, you will be told you have an infection when you may not have an infection, and obviously this will create significant distress, which we do not want to place you under. If I feel you do need to go to the emergency room, I will call the emergency room ahead, and I will alert the physician or the provider that you will be coming, and to call me immediately when you arrive. Other risks we discuss with regard to knee replacement. There's A risk of what's called deep vein thrombosis, which is a blood clot, which can occur with hip or knee replacement. The deep vein thrombosis typically occurs in the veins of the calf, usually on the side where the replacement was performed. This is also a very rare complication, but if it occurs, the patient may experience significant leg swelling and pain, and it will typically be most pronounced in the calf, but it will typically involve the entire leg. Now, this is not the typical swelling we see in the knee after the replacement. It is much more pronounced. The patient, again, will have significant pain, and oftentimes the pain is greatest in the calf and not over the knee. If a patient is concerned that there is a blood clot, they need to call the office immediately, and the patient will typically be sent for an ultrasound to check for the blood clot. While the blood clot in the leg will cause significant pain and swelling, some of which may never go away, the bigger concern is the blood clot could travel to the heart or the lungs. If the blood clot travels to the heart or the lungs, this is what's called a pulmonary embolus or a cardiac embolus. And these situations could result in death. So it is a very grave concern if a patient has a blood clot, and especially if it could travel to the heart or the lungs. Following the joint replacement surgery, patients are placed on 2 81 milligram baby aspirin once a day for 2 weeks. This is to prevent blood clots. If a patient normally takes blood thinner medication prior to their joint replacement surgery, they do not need to take the 81 milligram baby aspirin as previously instructed. The patient should instead resume their blood thinner medication the day following their joint replacement surgery. Again, if there is a concern for a blood clot, the patient should call the office and will likely be sent for an ultrasound to check for blood clots. If a patient does have a blood clot, they will require prescription anticoagulants for up to 6 months following the surgery. Other risks regarding knee replacement include risks to nerves or vessels. The nerves and vessels are in the back of the knee, and the surgery is in the front of the knee. So I have never had a patient experience injuries to those structures, but we do know that the structures are at risk, and therefore we explain that risk to patients. One of the most important areas of concern with knee replacement is the recovery and the risk of knee contracture. What does that mean? Following the surgery for a knee replacement, we need patients to move their knee. If the patient does not move their knee, meaning fully straight and fully bent, then they will develop contractures, which will result in decreased knee range of motion, which will also result in less than optimal results. As a result, we want patients to obtain full knee range of motion within 4 to 6 weeks following the procedure. If a patient does not obtain full range of motion in that time, oftentimes we will take the patient back to surgery for what is called a manipulation under anesthesia. That basically means we will not make any incisions in the knee, but we will take the patient to surgery where they will undergo general anesthesia, and I will move the knee to break up any scar tissue that has developed. In this way, the patient will still be able to obtain full function of the knee replacement, but if they are not able to achieve that motion on their own, then we will achieve it for the patient. This is very rare, but it is something that we do have to do on occasion. Other risks of knee replacement include fracture, meaning when we put the replacement parts in, there is a risk that the femur bone, the tibia bone, or the kneecap, which is the patella, could sustain a fracture, which is a break. If that is the case, then additional steps may be necessary to treat the fractures. This is also very rare, but it is a complication that we discuss. Again, we discussed nerve or vessel injury that is extremely uncommon, but it can happen. If it happens, patients might have numbness or tingling or weakness following knee replacement. I always tell patients that the knee replacement side may always be warmer than the other side. It may always have some degree of swelling that persists and is permanent. When we perform a knee replacement, we put in parts that were not there originally, and they take up space, and that extra space may result in the knee looking slightly bigger or more swollen. Some patients will have some numbness or tingling over the incision line that may never go away. Some patients may always have some warmth or redness that never goes away. That does not mean there is infection, but it may be something that is permanent. Patients who are undergoing knee replacement will receive a phone call the night before their surgery with final instructions in terms of time to arrive at the facility and location where the replacement will be performed. If the patient is having surgery on a Monday, that phone call will come on the Friday before the surgery. Patients are instructed to not eat or drink anything after midnight the night before surgery. That means no food, no water, no certs, no gum, nothing in the mouth. If a patient has something to eat, there is a chance the anesthesiologist will cancel the surgery. The surgery is done under general anesthesia, and typically we also will have what's called a nerve block performed to numb up the knee to allow for decreased pain following the surgery. In addition, we will utilize local numbing medicine in the knee joint to also decrease post-operative pain. The other things that will decrease the post-operative pain is ice and elevation, which will be very critical in the first 1 to 2 weeks following the surgery. Patients typically are discharged the day of the surgery or may require an overnight stay in the surgery center or in the hospital facility. The criteria for patients to be discharged is very simple. 3 criteria. Number 1, the patient's pain is well controlled with medication that they can take orally by mouth. Number 2 is the patient does not have any complications from the anesthetics. We need to make sure that the heart rate, the blood pressure, the vital signs are stable. We need to make sure the patient is not experiencing significant nausea or other symptoms related to the anesthetics. The third criteria is that the patient is mobile. The mobile aspect of things is basically the patient needs to be able to get up and out of bed. They may use a walker or a cane or an assisted device, but they need to be able to get up and out of bed. They need to be able to walk through the hallway. They need to be able to go up and down some stairs. And they need to be able to get on and off the toilet seat and in and out of the shower. If patients can accomplish those goals, then they are safe and stable from a mobility standpoint to be discharged. The surgery itself normally takes about an hour and a half. Following the surgery, the patient will go to the recovery room. I will see the patient prior to the surgery, at which point we will answer any additional questions, and also I will sign the surgical site. We know which side we are working on, but we take special precautions to make sure that we do not perform surgery on the wrong side. So we will take a marker and sign the surgical site in the preoperative area prior to the surgery. At that time, I will also obtain the contact information for family members, and that way I will call the family members following the surgery to report that everything went fine and give any further instructions. Again, if the patient is doing well and meets appropriate criteria, the patient will be allowed to be discharged the day of the procedure. Otherwise, the patient will remain typically overnight. Knee replacements are slightly more difficult to recover from than hip replacements, and it involves that range of motion that we've already discussed. With that said, we want patients to walk on the knee right away, and we want to work on motion right away. When the surgery is performed, we will place staples over the incision. We will place a waterproof dressing over the incision. That's the bandage. And then we will wrap the leg with an ACE bandage and some cotton padding. That dressing stays on for 1 day. That dressing is then removed on the morning following the surgery, and the waterproof dressing will be evident and will be in place. Patients can shower that next day with the waterproof dressing in place. They should then begin motion, which we will discuss in just a moment. The dressing should stay on for up to 3 to 7 days, but then it should be removed. At that point, patients can still take their daily shower and get the staples wet. After the daily shower, we recommend putting a clean, dry dressing over the incision. If there is no drainage whatsoever, then patients can avoid the dressing if they choose. The best way to put the dressing on, we recommend patients utilize what's called TED hose or compression stockings. The compression stockings come up the leg and they allow for compression to decrease swelling after surgery, which we have already discussed. The compression stocking can often hold a bandage over the knee replacement, so no ACE wraps or adhesives are required. On the first day after surgery, we want patients to begin their range of motion. They do not need to use weights, and the exercises are not difficult to perform, but they need to be performed for the patients to optimize their surgical results. Typically, for 4 to 6 weeks following the surgery, a nurse will come to the home to check on the patient, obtain vital signs, and check the wounds. In addition, a therapist will typically come to the house to make sure the patients are working on their motion. Ice, elevation, and range of motion are the 3 critical steps that patients need to take part in following the procedure, especially the first 10 to 14 days following the procedure. The patients will be seen 2 weeks after the procedure, and that appointment should be made by the patient at their preoperative visit. Patients are typically seen 7 to 10 days prior to their surgery, at which point we will review all of what we have just discussed. They will then be seen 2 weeks after the surgery to check on the wound and to obtain x-rays. Patients will be seen 3 weeks after the surgery to remove their staples. Patients may be given prescriptions for outpatient therapy at 3 to 6 weeks depending on their progress. At 6 weeks, patients will also be seen, and at 12 weeks, patients will be seen. Most patients are back to full function without restrictions by 12 weeks following the procedure. Some patients will recover quicker than this time frame, and rarely some patients will take a slight greater amount of time. With regard to exercises and range of motion following the surgery, I recommend 4 times a day patients perform the following exercises. I recommend 4 times a day because I tell patients they should do these exercises before breakfast, before lunch, before dinner, and before bedtime. Exercises should all be performed at 5-minute increments. The first exercise is basically just to sit with the leg extended on, in this case, a chair. As you can see, I'm sitting in a chair, and if the replacement was performed on the right knee, what we recommend is the patient put the heel on the chair and allow the leg to simply straighten. Gravity will help the leg straighten, and this is what we want. While the patient is doing this, we recommend putting ice packs over the knee to decrease swelling. Oftentimes, after the knee replacement, it might feel better to keep the knee slightly bent, but the problem with this is if it stays bent, it will develop scar tissue and the patient will not be able to extend the knee, which will significantly compromise the results of the replacement. So, for at least 5 minutes, we tell patients to put an ice pack on and straighten the knee. While the knee is straight, you can also push downward to help straighten it if necessary. After that 5 minutes is complete, you can then take the ice pack off, and we recommend 5 minutes of what's called straight leg raise. The straight leg raise is simply to lift the leg. This will contract the quadriceps muscle and it will strengthen the leg. When the patient lifts the leg, they should lift it 6 to 8 inches above the chair and give it a 3 count. So 1, 2, 3, and then back down. You can take a breath, lift it, 1, 2, 3, let it back down. That should be performed for 5 minutes. The last 5-minute exercise is to bend the knee. And so at that point, we tell patients that they can take the leg down and they can lift the leg and simply bend and straighten. Bend and straighten. Bend and straighten. Again, for 5 minutes. You can rest in between, but for 5 minutes. If the patient is not able to have full extension and flexion of the knee to 90 degrees by 4 to 6 weeks, we will recommend a return to surgery to manipulate the knee. Icing and range of motion exercises are critical through that first several weeks following the procedure, and this is what we would recommend. This concludes the video regarding total knee replacement. Patients are instructed that they can review this video by simply going to our website, which is AOSMLV.com. Again, AOSMLV.com. Patients should then click on the provider listing and go to Dr. Michael Trainer and go to the bottom, and you can click on the video for total knee arthroplasty or total knee replacement instructions, and you can re-watch the video if you have any questions. Thank you.